So with that, I'm going to ask my colleague, Alex Stockdale, to come on and describe some work that he was conducting along with the WHO Hepatitis B Guidelines Committee to look systematically through the global literature for hepatitis B interventions and strategies for care. So Alex, thank you so much for joining today, and I'd love to pass over to you to share your slides and tell us a little bit about what you learned with the global systematic review. Thank you very much.
Great. Thank you very much, Neil. Thanks for the introduction. So I am a physician. I worked in Malawi for quite a few years, and I'm going to be presenting data from our systematic review commission and funded by the WHO to support the WHO guidelines process. So we were specifically tasked. Let me see if I can advance this. There we are. So these are the contributors, predominantly colleagues in AIMS India, Harvard, and WHO. We aimed this review process to look for evidence in the literature of different models for how to deliver hepatitis B care. And specifically for this talk, I've been asked to concentrate on low and middle income countries. We tried to look for evidence on the outcomes across the entire span of the HBV care cascade, that is from diagnosis to being assessed for treatment, for starting on treatment, and then for being retained in care and followed up. So that's the entire span of the care cascade. So there's several steps along the way that we evaluated. And then finally, to look at whether we could identify any association between these different approaches that have been described and the effectiveness. So we also conducted a literature review for data over the last 10 years and applied a variety of analytical approaches to pool the outcomes and compare the outcomes. So our search identified 92 eligible studies reporting data from clinical cohorts. The majority of these were observational studies. And in terms of specifically low and middle income countries, 8 were from low income and 31 from middle income. So most data are derived from high income settings. So this is a map of the studies according to the size in terms of how many participants and the type of the study. And you can see most are from hospital-based or co-managed primary, secondary care, and mostly from high income, as I said previously. And again, now this is now just concentrating on lower and middle income data, so predominantly from the Western Pacific region, particularly from China, with a smaller number of studies from Africa and very few studies from South America. If you look at the region, so a good spread of global distribution and more data coming in latter years. And in terms of high country income classification, predominantly high income. And you can see the different distribution according to the data publication on the right-hand side. So I'll start by saying we didn't find any interventional studies, that is a randomized control trial assessing the effectiveness of interventions for care delivery among people living with hepatitis B. So that's a massive care gap. So if we think about the challenges facing us as physicians trying to care for people with hepatitis B in low and middle income countries, we've got fantastic diagnostics. We've got tests at point of care that are very effective. We've got treatment that's safe, effective, and cheap. So we're in a very enviable position in terms of physicians, but in terms of making it happen on the public health level, this is where the evidence gaps are. We don't know how to effectively introduce this in a sort of service delivery plane. So if we look at what these studies that we identified actually focused on, so the colored map on the right-hand side, the rows going down from the top to the bottom are the different studies, and the x-axis going from left to right are looking at what element of the care cascade was assessed. So that's eligibility for treatment after diagnosis, the proportion eligible for treatment, those who started if they were deemed to be eligible, those who retained in care, and then finally suppression. And you can see that the early parts of the care cascade are quite well described across the included literature. This is just for low and middle income countries. But when you get into the latter parts of the care cascade, that's getting people onto treatment and retaining care, there's very, very, very limited data. I wanted to highlight a few examples of models of care from across the different included studies. So these are some of the models of care that you'll probably hear described, because I know a lot of the authors, the senior first authors, are present in this in the webinar today. So from Ethiopia, either Michael and colleagues looking at task sharing within a specialist care setting from Sierra Leone and Zambia, looking at how to integrate with an NCD clinic, looking at the concept of doing mass community testing and then linkage to specialist care. Then some primary care models or community-based models, such as a pop-up community with outreach, so same-day initiation, visiting specialists with community testing, and then some other examples, such as supporting within the primary care concept, or doing community screening and then linking to liver clinics. So that's from the Prolifica cohort from Shabril and colleagues. And then there's some examples of a model of care of integrating within an HIV clinic. So there are examples out there of some innovations in terms of models of care. In terms of what were the outcomes from these studies, you can see that the linkage to care, which is defined as patients newly diagnosed with hepatitis B having an assessment of whether or not they require treatment, and that's according to the local guidelines in the area where the study was set. And you can see, for example, specialist care, very, very limited data on outcomes from low and middle income compared to other regions of the world. But the available outcomes show sufficient, substantial lacuna in terms of loss from a diagnosis to getting that assessment completed. And with some of these more innovative models, such as same-day clinics, or community screening linking to visiting specialists, some of the higher rates of linkage, but some real drop off, and particularly that's the case in primary care type models. In terms of patients commencing on treatment once they're deemed to be eligible, again, there's quite a few areas where there's a significant loss. And this was observed across the entire global review. There wasn't anything specific to low and middle income country, but again, some of these more innovative models of care, such as the pop-up clinic, same-day test and treat models, show some promise there in terms of improving the conversion rate from being eligible to commencing therapy. In terms of retention and care, this is an area that requires a lot of focus, I think, and a lot of attention, and probably where there's the greatest lacuna in terms of the available evidence. So from this small number of studies, but this was a finding mirrored in the wider review, there's a real loss to follow up. So between an interval there of 12 and 48, between 1 and 4 years, you could see that there's a huge loss to follow up across the entire patient cohort. So, 3/4 of the cohort being lost over time, not returning for care. And then if you compare that with patients, specifically those who are eligible and indeed commence antiretroviral therapy, that's with tenofovir and tenofovir, you can see that the loss to follow-up is much smaller, so just 25%. So there is an association that was observed in this and in the wider review of an association between loss to follow-up and whether or not patients receive treatment. Finally, if we take our global findings, so this is our care cascade from all 92 studies, you can see for hospital-based specialist care, which is the sort of what we took as our sort of bar for the standard of care, but the kind of the traditional standard. But of course, we need decentralized, we need innovative models. But this is just using this as our benchmark. You can see going left to right there, the loss from diagnosis, about more than 1/4 of patients on average for our pooled review were lost between being diagnosed and getting assessed for whether or not they needed treatment. And a lot of the loss to follow-up, for example, is in patients not getting specific measurements such as HBV DNA quantification. And the next drop-off, about 20% lost from being deemed to be eligible but not starting therapy. And then the next drop-off, about 15% for retention and care. This is specific to the patients who had started therapy. So we're experiencing drop-offs at every stage of the care cascade. And then finally, 1/3 of those patients who commence antiviral therapy not suppressing. And you can compare that with the one on the right. There's much greater drop-off for retention and care among patients who are told that they're not eligible for care. And if you compare that with, for example, with HIV, I'm an HIV physician, and the culture is very different between the two diseases. And you can see, for example, there are the much lower rates for the sort of global average for the UNAIDS estimates. So about 10-15% drop off at each stage compared to the much higher losses that were evident in our review of the literature on hepatitis B. So to conclude, we've got very limited available data from low and middle income countries, which is a real shame, and it's a real acute area of need to urgently get operational, interventional, and innovative research to answer the question which we need to know: how can we effectively deliver care in these settings for people living with hepatitis B to prevent death from cirrhosis and liver cancer. And bearing in mind that in many regions of the world, for example, in WHO Africa region, liver cancer is the second commonest type of cancer in men and the fourth commonest in women. How do we get care pathways and optimize the timing of follow-up? How do we optimize how we construct our clinics and follow patients and avoid this huge loss to follow-up? That we've seen from the available evidence, though it's limited, that there is a real problem, particularly loss to follow-up, particularly among patients not on treatment. So we need to evaluate some of these models that have shown promise here from this emerging literature. Overall, I would summarize by saying that we've got significant knowledge gaps, particularly in the latter parts of the cascade, and a real lack of randomizer interventional evidence. Thank you very much.